Yeah, hello everyone. Good afternoon. My name is Zechmeister. I'm sorry that I can't be here in person today, so that's why the presentation is recorded, but maybe if I can make it, I will just jump in later on for questions, hopefully. Yeah, so I'm an occupational therapist working in hand therapy for the last couple of years here in Abu Dhabi, and I would like to present today my case for the CMMS. So my patient was or is a 32-year-old male. He came to us after an explosion injury to his left hand, and he sustained an open fracture of his right clavicular and a degloving injury of his left wrist. The injury happened in August 2022, last year, and he had two surgeries on the 7th of August and on the 12th, which was a debridement of the wound. His diagnosis was the fracture of the right clavicular, which was treated conservatively, and the degloving injury of his left wrist, which resulted in a medial and ulnar nerve injury and a radial artery injury. The surgical treatment was two debridements and the flap of the wound, and the flexor tendons, FCR, FPL, and also palmaris longus, they needed to be repaired. His social background, this patient is a 32-year-old male. He was otherwise healthy and active. This was a work-related injury. He is a manual worker, so he was trying to fix a gas leak at work. And when the injury happened, and he's right-handed, he's married, had 3 kids, and he's living 3 hours away from the hospital, so means he couldn't attend the sessions regularly. And also his work was 1 hour away to the other direction. Oops, sorry. In the initial assessment, this was end of August, so 3 weeks after the injury was the first time we have seen the patient. I've seen the patient. He presented with an edema on his left hand, which was distal to his scar on the wrist, so his hand was swollen. He already reported a numbness of the left hand and quite severe pain, so he reported 6 out of 10. His hand and his wrist were very stiff. He wasn't able to close his hand or to move the wrist because of pain and stiffness. The Kapanchi score was 3 out of 10, and his active range of motion in the MCPs was 10-degree lack of extension and only 30-degree flexion of the MCPs, yeah. The wrist extension and flexion was around 15-degree and 30-degree inflection. Prosupination was also limited to only 30-degree pronation and 10-degree supination, and he was unable to use his left hand functionally. He couldn't do anything with it. So this was the movement on 1 month later when we started the treatment. He came once a week, sometimes he could make it twice a week, and we did the normal hand therapy like manual therapy, mobilization, scar management, edema management, and pain management.
Here we go.
Yeah, on the right we can see the movement, what he was able to do by that time.
Yes, very good. Close even more. Try to reach your palm, try to reach you.
You can see his wrist is in flexion. He was unable to close his hand fully.
Now you can help with the other hand.
And even passively, he had a hard time to close his hand. It was very painful.
Very good. Very good. Feel that they are touching. Yes, good. And now you remove this hand and hold it close.
And he couldn't maintain
close, hold it close, hold it close. Yes, very good. Yes,
actively. So for the first 1 month, we'd had the weekly visits for pain, scar, edema management, as I just mentioned, desensitization, of course, mobilization, and we started with hand function exercises. At night, he got a wrist extension splint, which was requested by the doctor. And yeah, so 6 weeks later, he was able to close his left hand actively. Also, his pain reduced quite a lot to 2 to 4 out of 10. And finally, we started on end of October with CMMS. So this was then 2 months after his injury. In our hospital, we don't have the plaster of Paris, so we use the soft cast material. I will come back to this later. So before we started the CMMS, this was what he was able to do. So he was able to close his hand.
So you close
pretty
your hand.
much. But you can see the wrist is still neutral to flexion when he tries to close his hand.
The movement is initiated by IP joint flexion and then MCP.
Also, you can see that the fingers are still swollen. He has difficulties to flex the IP joints. These are still quite stiff. Also, MCP joint doesn't fully flex. So we started end of October with the soft cast. We started with an intrinsic minus cast for 2 weeks. Then after that, I changed to the intrinsic plus cast for another 2 weeks. Then we changed to the intrinsic plus bivalve cast, which he was wearing for 2 weeks most of the time. And then we started weaning off for another 3 weeks. Additionally, in the end, when he was weaning off the bivalve cast, we added an MCP blocking splint and night resting splint. I will come back to this more in detail later. So this was the first cast I applied for the patient on end of October, the intrinsic minus cast. So means the MCPs were blocked in extension, and the exercise for the patient was to flex the IP joints.
The exercise, you try to curl in the tips of your fingers, close it as much as you can.
You can see he was struggling most with the index finger.
You close it. And you open. Close the tips of your fingers. Try to reach the dots.
And I place the wrist in extension.
Close it again. The exercise you try to.
After 1 week, the patient came for a follow-up appointment. He showed already an increased IP joint flexion, and the edema in his fingers was reduced, and the patient in general felt already better with the movement of his fingers. But we kept the splint for another week.
Close your fingers.
Now here you see the index finger has improved already.
Close.
And it was much easier for him to flex the IP joints.
Close. And open.
So after the 2 weeks, we changed to an intrinsic plus cast with an increased wrist extension because the wrist was really extending much better. He felt comfortable with it. And here you see the movement with the intrinsic plus cast. What I noticed then that the palmar crease could have been more freed. I mean, in the video, it looks even a bit more than it was actually, because the upper part was soft material. I put some soft padding, but it could have been more free to allow more MCP flexion.
Close your hand and open.
After 2 weeks of the intrinsic plus, we removed it, and we could see that his wrist extension has improved a lot. He was able to close all the fingers easily. So wrist flexion extensions was easy for him.
And forward and back.
And with this result, the patient was already very happy. In the finger, he's still a bit struggling with the full flexion.
Right.
his main concern at this time is still the numbness in his hand and the electrical sensation he had on touch. So when you touch the scar area or the wrist area, he felt this electrical sensations. But with the movement, patient felt very happy and easy to move.
We start with the wrist.
Then another 3 weeks later, patient came back again. He was able to close all fingers, but as you can see here already, the wrist was in neutral, so he couldn't maintain much of the extension which we achieved, despite wearing the cast still on off. And the patient in general is very compliant. So he did the exercises and he was wearing the cast as requested, as ordered. So this is the devolving cast. So we opened it on the side and put the straps.
If you close your fingers.
And in the cast, he moves nicely.
And open. And this is the exercise now.
So, and then another 2 weeks later, he came back and his wrist extension was really very much decreased. The edema was decreased as well, so he didn't have that much swelling anymore, but the wrist extension was a bit disappointing, but fingers were moving easily. He was happy about that. Still, the numbness and the electrical sensation haven't changed yet. At this stage, the patient didn't want to wear the cast anymore, so I gave him a thermoplastic night resting splint to help with the wrist extension, and I added an MCP blocking splint. Unfortunately, I didn't take a picture. So what I did, I used the Orphicast and blocked the MCP's inflection. It was around here, like a figure of 8 around the MCP, so that he could still use his hand with the splint. And this he tolerated very well during the day, and at night the thermoplastic splint. So what therapeutic intervention were done? So we have done general hand therapy for active and passive range of motion for his wrist and for the fingers. We work with manual therapy. We are applying K-laser, desensitization program, scar pain and edema management to keep the scar flexible, to help further with the swelling to reduce, and splinting and casting. Again, as a summary, 2 weeks intrinsic minus, 2 weeks intrinsic plus, then 2 weeks intrinsic plus bivalve with exercises in between in the cast and also without the cast, and then 2 weeks of weaning it off. After 3 months, so the patient was still coming once a week or once every 2 weeks as his work allowed. He came for hand therapy and he did his exercises at home, but still after 3 months, the wrist extension was slightly improved, so he was able to extend the wrist a bit more. He still has some edema on the dorsum of the hand, but this is a very mild one. And what he was reporting by that time, that the numbness is still there and the electrical sensation has increased. So on touch of the wrist, on the scar, the area of touch which triggered the electrical shocks was smaller, but it was quite intense. So he was really sometimes jumping almost off the chair when you touch this area. And he didn't wear the night resting splint anymore, because then he started feeling that this increases his electrical sensation. When he goes on wrist extension, the electrical sensation was increased for him. That's why he didn't want to wear it anymore. And he reported also that he avoids extending the wrist or doing something in wrist extension because he's afraid of these shocks and he can't tolerate it that much. Here's an overview for the active range of motion measurements. So as you can see before and after, the wrist extension is reduced, but flexion has increased. In general, I'm happy with the MCP flexion, which has improved a lot with the CMMS technique, and also the IP joints, PIP, DIP joints, absolutely good outcome over the course of 6 months. And especially if you look at the improvement with the cast, so the first 2 measurements, he did a good improvement. Regarding the pain, he improved from 0 to 2, but these electrical sensations, when they are coming, of course, this goes really high up in pain-wise. Numbness is still there, but this is something he accepted it for now, so he can deal with it, and it's only the index finger by now. Index finger and tip of the middle finger. Kabanchi score has improved from 3 to 10 out of 10. And then the muscle power. I started measuring the muscle power beginning of the year, which was quite weak. So I gave him the therapeutic strengthening exercises, which we have done before as well. And by that time, he was still wearing the night resting splint. And then he improved even more to 8 and 13 kg on the left side. And this week I've seen him again and measured it, and I was surprised that his left hand function or his left hand showed only 2 kg. What he was reporting is the electrical sensation, these electrical shocks just limit him in grasping further, because as soon as he strongly grasps, the electrical sensation comes in and the pain. So that's why he is avoiding it, to use the hand for heavier activities. So my reflection. So in general, I can say the patient achieved good improvement, especially over the first 4 weeks of CMMS treatment. So this was amazing to see, and the patient was very happy about it. Also, the doctors were satisfied with the progress. So this means initially he had a huge benefit of CMMS, and he started using his hand functionally after 1 month of using the cast. As I said, he's still continuing hand therapy as much as possible, once every 2 weeks, because he's back to work now. He's going on light duty, so he's not doing his usual job anymore, but so far he's okay with it. And yeah, the question is, could we have achieved an even better outcome if I would have casted it longer? So, and if I wouldn't have gone too much into wrist extension, or that if we would have used the cast longer, that the wrist extension could have been maintained. But still, this nerve issue is something what he's reporting, which is his biggest problem at the moment. So therefore, the pain is limiting his progress. He's using his hand, he tries to adjust to it, yeah, but it's not the outcome what we would have expected. Nevertheless, the patient is happy compared to before that he improved. So then to what's one part of the presentation or of the topic, plaster of Paris versus soft cast. I just used the soft cast because it was too difficult to get plaster of Paris to our hospital because of all the process. And I can say for me, it was easy to apply. It was easy to handle. The advantage is definitely that it's a lighter material. So the patient doesn't have this heavy weight of plaster of Paris on his arm, and while it's still giving the stability and is rigid. So I can't compare it directly, but I would be curious if there are any possible advantages, disadvantages of plaster of Paris and to soft cast, if maybe someone else has any experiences with it. So I would like to be happy to hear from you And yeah, hopefully by that time, I'm joining you already for question and discussions. If not, then maybe Robyn will give me a feedback later. Yeah, thank you very much, everyone, for attending the presentation. And if you have any questions, you can put them in the chat and maybe Robyn can forward it to me, or maybe I can attend. Thank you very much and have a good day. Bye-bye.